This is Chapter 10 on fluency disorders. The focus questions for this chapter include: what is a fluency disorder? How are fluency disorders classified? What are the defining characteristics of fluency disorders? How are fluency disorders identified? And how are fluency disorders treated in evidence-based practice? We'll review all of these topics within the lecture for this chapter. First of all, starting with what is a fluency disorder. The textbook definition is a descriptive term used to characterize the flow of speech during communication. Disfluency is the speech behavior that disrupts the fluent forward flow of speech, such as pauses, interjections, and revisions. There are core and secondary features present in a fluency disorder, and we'll go over some of the terminology that is used when talking about fluency disorders. We'll also look at the prevalence and the incidence. So fluency, as we said, is a descriptive term used to characterize the flow of speech during communication. Speech is fluent when it has a typical rate and rhythm and appears smooth, effortless, and automatic. In a fluency disorder, stuttering and cluttering are two types of these disorders. Stuttering is the most common type of fluency disorder. Stuttering is classified by speech with an unusually high rate of stoppages that disrupt the flow of communication and are inappropriate for the speaker's age, culture, and linguistic background, including dialect. Also, it's a disturbance in the normal fluency and timing patterns of speech, and a disturbance in social communication, academic performance, and/or occupational achievement can be the result of the fluency disorder. Within fluency disorders, there are core and secondary features that are present. These core features or primary characteristics of fluency disorder, there are three types that are predominant, and these are repetitions, prolongations, and blocks. And we'll look at all of those more closely. There are secondary features that result from an individual's excessive mental and physical efforts to promote fluent speech and to disrupt disfluent speech. There are escape behaviors that are present or avoidance behaviors that might be present. Terminology used be stuttering, a stutterer, stuttering child, or a child who stutters. Prevalence and incidence of stuttering is the rate of about 1 in 100 persons. The incidence rate of about 5 in 100 persons. 5% of people have stuttered sometime in their lives, but only 1% of those are currently stuttering. 1.5% of children under age 10 as compared to 0.5 to 0.7 of adolescents and adults who have a fluency disorder. Males are more likely to stutter than females. And recovering from stuttering, recovery is in conjunction with treatment is called assisted recovery. Unassisted recovery and spontaneous recovery refer to recovery that occurs without the presence of treatment. Spontaneous recovery occurs in about 75% of cases. Looking at developmental stuttering and stuttering-like disfluencies, types of these stuttering-like disfluencies include part word repetitions, syllable or single syllable word repetitions, sound prolongations, blocks, and broken words. In preschoolers, core behaviors include repetitions of words and sounds. This might be like, I want something to eat. Or it could be, I want to look at that. It could be sound prolongations that are more like, I want to look at that. Or blocking that occurs, which may sound more like the child just can't get the sound out at all. Secondary behaviors that might be included are head nods and eye blinks and interjections such as or In school-age children, core behaviors that might be present are, again, prolongation when a sound is held longer than normal. With a prolongation, the airflow continues, but the articulators seem to be stuck. I want more cake. Or again, the blocks becoming more prevalent and lasting several seconds at this point. This is when the airflow and the articulatory movement completely stop during production of a sound, and these can last up to 5 seconds. And then along with the core behaviors, some secondary behaviors might be present, and these are going to become more evident and habitual. Some of these, like we said with the preschoolers, might be eye blinks, lip tremors, head jerks, using some fillers, pauses, and word changes. At the intermediate level, there may also be other things that are going on that children school-age children might be using to make their stuttering seem like it's not there quite as much. Adolescents and adults, the core behaviors include some of the things that are similar to those of school-age children, but they may not be quite as evident because adults and adolescents are better at trying to use avoidance or escape techniques, and we'll talk about some of those later. And then blocks, again, become more prevalent and last several seconds. And then secondary behaviors are much more sophisticated because people who are adolescents and adults become much more sophisticated at avoiding and escaping. In acquired fluency disorders, these can emerge at any time across the lifespan. They can result from illness, trauma, or an accident affecting the brain or psychological trauma. The term neurogenic stuttering is used when stuttering results from brain injury or neurological insult. And the term psychogenic stuttering can result from psychological trauma. Both of these occur less frequently than developmental stuttering, with psychogenic stuttering being the rarest of the 3 types. Some causes of neurogenic stuttering might include stroke affecting both cortical and subcortical areas, TBIs, epilepsy, metabolic disorders, and tumors. And some of the causes of psychogenic stuttering might include serious trauma and a history of psychiatric disorder. Talking about cluttering, this is a rapid or unusual rate of speech that results in disfluencies, frequent and unusual pauses, and a blending of sounds in words. Disfluencies consist of interjections such as and repeating of phrases, and incomplete word production or breaking down of individual words. Articulation errors are common with people who show signs of cluttering. What are the defining characteristics of fluency disorders? The most readily apparent characteristic is the disruption of speech with disfluencies for the intermediate and advanced stutterer. And these include primarily sound and word repetitions, sound prolongations, and blocks. Let me go back for just a minute. Primarily sound and word repetitions. There can be part word repetitions, such as "it's my baby." Single syllable word repetitions. My friend is here. It's an example of that. And then it can be in blocks, like we talked about before, where the articulators and airflow completely stop during the production of a sound or word. There are also some core behaviors and some secondary behaviors with these types of core features that were just described, the sound and word repetition, sound prolongations and blocks, and then some of the secondary behaviors such as the head jerking or head nodding and eye blinking. The definition of a core feature emphasizes speech disfluencies as the original and primary source of communicative difficulty experienced by individuals with fluency disorders. These core features of fluency disorders include the four types that we just talked about: part word repetition, single syllable word repetition, sound prolongation, and blocking. Again, looking at secondary features, we'll go a little bit more in depth about escape behaviors. Some secondary features, including escape behaviors, is when an individual develops a way to get out of a moment of stuttering. And some avoidance behaviors used are word and sound avoidance, specifically circumlocution, when they're just kind of going around the word to come up with something else or another word. And then situation avoidance, where they may just avoid the situation to not have a moment of stuttering. They would just steer clear of a circumstance where they feel like the stuttering is probable. Some of these situations can include answering the phone, introducing yourself at a party, ordering food in a restaurant, asking a price of something in the store, or asking for directions when somebody is lost. Feelings and attitudes play a really big part in secondary features. Obviously, it's not surprising that people with long-term fluency disorders have a tendency to develop negative feelings toward communication. People who do stutter might feel fear, frustration, and embarrassment, um, and to the point of trying to avoid um, communicating in situations where they feel like they are going to stutter. Looking at causes and risk factors. What causes the emergence of the core features of fluency disorders, which lead to secondary features? Um, the cause of stuttering is elusive, which is not necessarily what people want to hear, especially those who stutter. They want to know what's going on and why it's going on. There are some predisposing factors um, that make an individual susceptible to a fluency disorder, such as carrying a genetic trait or having an overly sensitive temperament. Some precipitating factors include both developmental and environmental factors that can worsen stuttering, such as age or stress. And the next slide kind of lays these out for us, what I just talked about as far as the predisposing factors, making a child more susceptible than other children. including family history, gender. Boys stutter more than girls do, differences in brain structure and neural physiology, and just the child's ability for motor speech coordination. And then talking more in depth about the precipitating factors of age and developmental stressors. Age can be a significant factor or risk factor in the development of a fluency disorder. In one study, the average age of stuttering emergence was 3 for boys and 2.5 for girls. The likelihood of developing a fluency disorder after age 6 is not as probable. Developmental stressors. Stress is not conducive to fluency, as we all have probably experienced at least this once in our lives. Some evidence suggests that a variety of developmental stressors may serve as precipitating factors in the emergence of stuttering in children, specifically those who are already susceptible to a fluency disorder. There are 3 categories of developmental stressors that can influence stuttering in children. These are communicative stressors, interpersonal stressors, and child factors. The communicative stressors are any features of communicative exchange in which children participate that are not well tuned to their speech, language, or cognitive capabilities. Features of other speech that children may find stressful include a rapid speech rate, use of complex syntax and complicated vocabulary, interruptions of the child's speech, overuse of questions and directives, and short wait times following questions. Self-awareness can come into play and is increasingly receiving attention as a possible precipitating factor in stuttering. Researchers and clinicians have viewed young children as being unaware of their own disfluencies, even children who are borderline and beginning stutterers. So a newer perspective on this, which has emerged in the past couple decades, is that children who stutter are aware of their disfluencies at an early age. In an interview with a 4-year-old who stuttered, the stutterer herself said, "Oh, it's so hard sometimes, the words won't come out." This is obviously showing that she's aware that it's difficulty for her to speak fluently. Can stuttering be induced? So there is a diagnosogenic theory of stuttering, where it's implied that disfluencies among children should be ignored and should not be treated, as this might precipitate development of a fluency disorder. Unlike many theories regarding what may or may not cause stuttering, this one was directly tested in an experiment of questionable ethics that's now known as the Monster Study. This was conducted in 1939 by a professor named Wendell Johnson. He himself was a stutterer and a professor at the University of Iowa. There was a 6-month study involving children in an orphanage where the experimenters and orphanage staff treated a select group of 5 to 15-year-old children who did not stutter as if they did stutter. So they were told things like, you have a great deal of trouble with your speech. The type of interruptions that you have are very undesirable. These interruptions indicate stuttering. You need to try to stop yourself immediately. Use your willpower. Just make up your mind that you're going to speak, things like that. It was reported that the researchers were able to induce persistent stuttering through these methods, although a recent reanalysis of the original data indicated that none of the children developed persistent stuttering as a result of the experiment. So the assessment process going along with fluency disorders, kind of similar to the assessment process in other types of disorders that we've studied in previous chapters, starts off with a referral. An assessment protocol is next. then a diagnosis and prognosis. So for the referral, a speech language pathologist who's specially trained for assessing, diagnosing, and treating fluency disorders can make that referral. Warning signs for developmental fluency disorders are looked at, and warning signs for acquired fluency disorders are also considered. Assessment protocol. There are 4 main questions to consider. Is the individual stuttering or at risk of stuttering? Does the individual exhibit any other communicative risk factors or disabilities? Is therapy for stuttering warranted? What therapy approach would be most beneficial? A case history and an interview will also be conducted. Then a speech observation, a questionnaire and survey, direct testing. Let me back up to that for a minute. So case history and an interview. The case history will be a very valuable part of a fluency assessment process. The case history is designed to clarify the history of the perceived fluency problem and place it within the context of the individual's life. Of course, for children, the case history informant is typically the primary caregiver. And for adolescents and adults, the informant will typically be the person who is actually experiencing the fluency problem. So a child's case history will include family demographics, developmental milestones, medical history, educational history, history of the fluency problem, including the parent's perception of the child's specific disabilities, or specific difficulties, and the way that the problems have changed over time. It's likely that during the case history and interview process, if the child is present, that the clinician may or may not hear the child stutter. So it's very important to listen to what the parent is saying about the frequency of the child's stuttering, because the parent is obviously the one who knows the child best, and you may be observing that child and talking with a parent for 30 minutes to maybe an hour at the most, and you may or may not hear disfluencies or stuttering during that time period. So keep that in mind. During a speech observation, obviously the observation of a child or the adolescent or adult speech is observed in a variety of situations, and probably is the most important part of this assessment. The clinician can observe and record the individual's speech in as many activities and locations as possible. These might include the home setting, in a classroom, at work, or in a social situation. The clinician is going to use a fluency charting grid, which is a tool for counting the total number of different types of disfluencies that occur within a speech sample. And by calculating the number of disfluencies within this sample, the clinician can estimate the percentage of disfluent speech in a given speaking situation. So, for example, if a child produces 30 repetitions, 10 sound prolongations, and 4 blocks in a sample of 500 words during play with a peer, the clinician could calculate that about 9% of the child's speech in the peer play context is disfluent. Looking at a questionnaire and survey. A clinician can use a questionnaire and survey to study an individual's feelings and attitudes about stuttering and communication. Obviously, this is going to be more geared more towards the adolescent and adult populations. It'd be very difficult for a young child to talk about feelings and attitudes about stuttering and communication, especially if the child doesn't understand why or how that stuttering is breaking down their communication. In direct testing, the clinician can use formal norm and criterion reference tests to examine an individual's skills in syntax, vocabulary, phonology, and pragmatics, and those can be compared with their performance with expectations from the norm samples. In diagnosis, a fluency disorder is more likely to be diagnosed when the following are observed during the assessment. 10 or more total disfluencies in a sample of 100 words, 3 or more stuttering-like disfluencies in 100 words, physical escape behaviors, and verbal avoidance behaviors. The physical escape behaviors might be head nods and eye blinks again. And then, as a reminder, the avoidance behaviors could be substituting words for words that they know that they probably are going to stutter when saying. Prognosis describes the likelihood that the symptoms of a disorder will be resolved with time or treatment. Factors that influence the prognosis are age of stuttering onset, length of time since the onset, types and numbers of core and secondary features, and the presence of individual risk factors. Each of these, of course, is going to be unique to each client that you are assessing. How are fluency disorders treated in evidence-based practice? Treatment techniques for children might include parent-implemented treatment and clinician-implemented treatment, which we'll look at a little bit later. Treatment techniques for adolescents will be looked at, and treatment techniques for adults, including knowledge about stuttering, reduction of negative feelings, and fluency building. And client and caregiver perspectives related to the treatment will it's also important to consider. So looking at treatment techniques for children, should preschool children with borderline stuttering receive treatment or take a wait and see approach? So looking a little more closely at the parent implemented treatment we talked about a couple slides ago, this is referred to as indirect treatment. Environmental models will avoid putting the child on the spot in social situations. Repeating what the child says to show that you are listening to what they're saying. Making comments when talking with the child rather than asking questions or making them feel like they're being drilled about something that might also kind of go along with putting them on the spot. And then modifying activities that seem stressful to a child, especially if a parent knows of certain situations that a child is going to experience increased stress. The parent might want to help that child in those situations by making them feel a little bit more comfortable, maybe letting them know that a stressful situation or a stressful activity is about to occur, to give them a warning about that so the child can be a little bit more prepared. Operant training models include identifying disfluencies and providing positive input and about those disfluencies, and prompting fluent speech and prompting self-correction. So an example might be if a child has or stutters on a certain word, you might use vocabulary something like, "Ooh, you said you had trouble saying train." If maybe a child says train, you could say, "Oh, you had a little bit of trouble saying train. Maybe you could try that again." And then the child could say train again. A term that I like to use sometimes is bumpy speech with younger children. And in the example I just gave, you might say something like, "Ooh, train was kind of bumpy. Can you say that again?" Not putting a lot of emphasis on it, but acknowledging that there was a stutter that took place and trying to go back and correct that. Clinician implemented treatments include the current approaches to stuttering treatment include stuttering modification, where you're going to try to manage and modify stuttering. This is to help the person who stutters to better manage the moment that they stutter, that moment when the person repeats, prolongs, or blocks on a sound. As stuttering progresses, these moments become more intense and long lasting. They are what the person with the fluency disorder fears and strives to avoid or escape. So, in stuttering modification therapy, the focus is going to be on helping the individual manage these moments and stutter more effortlessly and less tensely. So, not trying to tell them to not stutter, but to maybe have an easier attack to the word. Or you may have heard of people trying to go from maybe a whisper to a little bit louder speech to try to help with the stutter that's going to occur. Then fluency shaping or controlled fluency can be coupled with careful attention to feelings and emotions towards stuttering and communication. And sometimes a combination of both stuttering modification and fluency shaping is used as in stuttering treatment. Looking at treatment specifically for adolescents, both stuttering modification and fluency shaping approaches are useful for adolescents. Stuttering modification emphasizes, again, teaching the adolescent about stuttering to demystify the disorder. Successful stuttering management program can be, or I guess, consists of 3 different phases. The first phase is confrontation of the stuttering, and the second, modification of the stuttering, and then the third phase would be maintenance. So for phase 1, activities might last about 2 weeks, where you're focusing on modifying the participants' attitudes towards stuttering, and treatment activities focus on eliminating avoidance strategies. So instead of trying to avoid stuttering, you're trying to kind of attack stuttering head on. They might advertise their stuttering in many different speaking situations and analyze their own moments of stuttering. Then in phase 2, which would last about a week, activities would involve learning specific techniques that help to lessen the severity of their stuttering moments, such as pullouts and cancellations. And then phase 3 activities involve developing an individualized maintenance plan to help the participants continue to use stuttering modification techniques after they leave this program. Treatment techniques for adults. A treatment for adults who stutter utilizes both the stuttering modification and fluency shaping approaches, or an integration of the two. So similar to what we just talked about for adolescents, looking at the their knowledge about stuttering. The treatment will help the adult understand and confront the disorder of stuttering. They examine their own core and secondary features and may even confront their own stuttering in a mirror or via a video to develop a catalog of their behaviors. And then possibly reduction of negative feelings, looking at the reduction of negative feelings. This treatment will help the adult reduce their fear, embarrassment, and discomfort associated with stuttering. They will be guided to view their stuttering with interest and curiosity, to discuss stuttering openly and honestly, and to resist the temptation for situation and word avoidance. So kind of just hitting the stuttering issue head on, and looking about ways to go about the stuttering more positively. And then fluency building. This treatment helps adults increase their use of fluency enhancing strategies and work through moments of stuttering. Strategies to increase fluency might include talking at a slower rate, using easy onset, and soft contact. using or working through and finding strategies to help adults work through the moments of stuttering or to stutter more easily will be helpful. Then lastly, looking at client and caregiver perspectives related to treatment, fluency disorders can affect speech and self-esteem and emotional well-being. Parents need to work with their child, and adolescents and adults will need to address the stuttering and the impact of the disorder that it has on their life in their daily settings in life, whether it be at home or at work or in social settings. And that's the end of the unit on stuttering, and thanks for listening.